welcome to this talk. I'm basing this talk around this book here, right, which is newly out, which is called Cancer and Infertility, A Story of Hope. And it's told in 12 Golden Rules. And we're not going to do all 12, okay? We've not got time for that. We're going to touch on 3 of those. And 2 of them are related to cancer management and doctor-patient communication. And the first is always tell the truth. Take great care with prognostication. Second golden rule is never say there's nothing more we can do. And the third is never give up, which is actually the story of Womb Transplant UK. Important to say to you that on the John Baines tour that we're going to do in Japan in the autumn, we've got some really fascinating visits to hospitals as well as a lot of really special places. On the days where there are no hospital visits, there will be, as you know, the way John Baines tours work, there'll be medical talks which will be given by myself and possibly my transplant colleague Isabel Quiroga, if she's able to make this tour. And we're meeting some really great people in Japan. The current president of the IGCS, Kiichi Fujiwara, has very kindly agreed to host us. So it's quite an inspirational tour, I have to say. So I go to the next slide. Well, actually, hang on a minute. I say I'll go to the next slide, nothing happens. It's because we need to use this, do we? Yeah, there we go. Okay, so there's my title, Cancer and Infertility, A Story of Hope. And golden rules. Never say never. Now, second one, always tell the truth and never tell lies. And of course, these are self-evident, aren't they? But if you always tell the truth and never tell lies, and you tell everybody the same message, you will be on the same side as the patient and her family and your own team. But we all get ourselves into difficulties, and I certainly have in the past with prognostication, that terrible question that patients always tend to ask, which is, how long have I got? And we all know that the answer to that is usually we don't know, we might guess. And it's very important not to get into that. And we're going to discuss some strategies as to how to avoid getting into trouble with that. It's never true that there's nothing more we can do. I was taught as a medical student, sadly it's a long, long time ago, by Sir Kenneth Calman, who's Professor of Medical Oncology at the time. And there was a famous story about Ken Calman then, which was that he'd said to a patient in the ward who was very close to dying, was there anything that he could do for her? And she'd said, I would really love to have my hair done. And he had arranged for a hairdresser and paid for it himself. And that all comes down to, and we're going to get into this in a bit more detail later, asking the right questions. So when we first meet patients, or never mind first meet them, as their treatment goes on, people always want a treatment timetable. We should back up with written information and pictures. And it's usually possible to finish a consultation in an oncological setting on an up note. Not always, I grant you. We know that we need to repeat the vital bits of our message, and we know that these days we should use the cancer word. So I'm now going to describe to you something which I developed with colleagues at Chelsea Westminster many years ago. And I know a lot of people, trainees, have gone on to use it in various places. It so resonated with patients that we, in fact, had a PhD student who did her PhD on the four-cusp approach. And her findings were interesting. So what this does is it allows patients to move from a position of anger, despair, potentially to one of hope. It allows the patient active management in her involvement in her own management. And it's a map for cancer patients. It's really important to say this is not a clinical model. It bears no relationship to the 4 FRCOG pathological stages of cancer. So cusps A, B, C, and D do not in any way relate to FRCOG 1, 2, 3, 4. And it's based on 3 important factors: physical, psychological, and then life expectancy and quality of life. And it's a way of potentially, totally truthfully answering the question, how long have I got, doctor? So here's the 4 cusps. Now, if we look here, we've got cusp A, cusp B, cusp C, cusp D. I want you to imagine that we're sitting in the clinic and we've actually got a piece of paper and we've drawn A, B, C, D, right? And cusp A is cured, and there's always inverted commas on when we first draw it. And there's living with cancer, there's pre-terminal, no inverted commas, and terminal. And I always say to patients, and I can think of one exception in 30 years where actually the patient was here. I say, you are not cusp C, and we draw a line through it, and you're not cusp D, and we draw a line through it, and we fold the paper. Now, I say this is important because that piece of paper comes out of people's wallets 1, 2, 3 years later. People keep it in their wallets. Really interesting. And our psychology student found that this aspect of the model was actually really important, plus the folding of the paper. So we're now down to looking at cusps A and B. Cusp A, cured in inverted commas, is a 5-year cusp. And so year 1, year 2, year 3, year 4, year 5. And at that point, you get in the cured circle and the inverted commas disappeared. And in most gynecological cancers, you can be regarded, as you all know, as cured. And that circular thing was the next thing which really appealed to people. If you've got a patient who needs chemotherapy, radiotherapy, not everything's come out, particularly if there's no surgery involved, then that patient we would put into the living with cancer. But we get them into remission 1 year, 2 year, 3 year, 4 year, 5 years. That gets your patient over into the cured circle again. And that's the nub of this, okay? So you've cured, living with cancer, pre-terminal dying. So cusp A cured. So the status is potentially curable. The duration, on some occasions, it may not last that long because of what we find out. But of course, what we're hoping for is a lifelong cure for patients. Our treatment, I'm a gynae cancer surgeon, gynaecological surgeon, radical surgery. And then, of course, we've got our colleagues in chemotherapy and radiotherapy with adjuvant treatments. And the aim that we're looking for is cure or prolongation of survival. So just to go back to this, that patient who has surgery, we're looking for them to go along this trajectory, 5 years in remission, and they get in the cured circle. So an example would be a cervical cancer, where we're going to do a Wertheim, and we get complete resection of the tumour with negative nodes. Well, that patient has a very, very high cure rate, and we would put her into cusp A. And we would be following her up, and when she gets the 5-year mark, we would regard her as, at that point, as more likely to develop an alternative tumour. Scenario 2, of course, is less common these days with high-resolution scanning, but you do the Wertheim, and unfortunately you find lymph node metastases. Now, that patient's going to end up with chemo and radiotherapy. Doesn't happen so often these days, I grant you, but that patient will be in cusp B. Back there. So we would say to her, you are here at the point where we finish the treatment, and we're looking to follow you up, and we hope that you are going to remain in remission. When you get to the end of that 5 years, if you're still in remission, you're going over here into the cured circle. Of course, if you recur, you go back to the beginning of this, depending on what the next treatment's going to be. So just flick forward. Another scenario, we've got a woman with ovarian cancer. Imaging says this is a stage 1A. We do our procedure, and it's confirmed. She's got a tumour confined within her ovary. She's got a really high, really high cure rate. Everything's looking good for her. So she's cusp A. Scenario 2, unfortunately, we open the patient. Again, this has become less common because of high-resolution imaging, but the small studs of tumour on the diaphragm that weren't picked up on imaging. That patient is going to have chemotherapy over a prolonged period of time, and she's gone into cusp B. And of course, this cusp B is status living with cancer. The duration, we don't know. It's months to years. And the treatment for the ovarian cancer patients, chemotherapy. For the cervix, it's radiochemo. And what our aim is possible cure, prolongation of survival, and improvement of quality of life. I made the comment earlier about never say never. And I kind of what I was coming from with that was that you can have a patient with a really good prognosis tumor, a stage 1A, grade 1 endometrial cancer. And I've certainly seen this once in my career. Good op, all cool. 9 months later, lung full of secondary tumor. And she, of course, dies. So the best of prognosis became the worst of disasters. Excuse me. And of course, the flip of that is you can get it the other way around. And I certainly have had a few patients with advanced ovarian cancers who have done extremely well, and in fact they've remained in remission for multiple years, 15, 20, 25 years. And going to the living with cancer, my own record patient who stayed, and she never got to the cured circle, but it took her 19 years to hop to cusp C with recurrent ovarian granulosa cell tumor, which we operated on again and again until it went wrong. And that takes us to cusp C. And one thing I would say to you is, if you use this model, and it's a very simple model, I know all of you who are watching here are experienced clinicians. To me, the hardest conversation you ever have is actually the cusp B to cusp C. That's a terrible conversation. Funnily enough, women have produced the model, the paper, from their wallet, purse, and said, I think I'm just hopping into cusp C. And it's actually made that conversation easier. So cusp C, pre-terminal, duration, weeks, months at most. The treatment is supportive care, and the absolute aim is improvement of quality of life. That's cusp C. And to me, the golden rule question here is that we mustn't presume to know the patient's problem. We need to ask the patient, what is it that you feel we could do for you? How can we help you? And it's clearly time to put one's house in order. So I'm going to give you 2 examples. There's a woman treated for stage 3B cervical cancer. She's had full dose chemo radiotherapy, and she relapses 3 years later. And at the point of relapse, she's got enlarged para-aortic nodes. She's got a large cystovaginal fistula with active tumor involvement. And I encountered this scenario. It's a long time ago now. Very, very memorable. Because I was on my ward round on a Tuesday late afternoon. It was a big teaching ward round, as we used to do with a lot of folk in tow. And we walk into this room, and there is this unbelievably angry woman. And the anger was palpable. And she said, I said, look, I know you're angry, but can you tell me what you're angry about? And she said, it's obvious. I said, well, I know it may be obvious to you, but it's not necessarily obvious to me. And she just sort of looked at me. I said, look, okay, is it that we can't cure your cancer? She don't be ridiculous. She said, but I've been told there's nothing more that can be done, right? So it's like, my goodness. So I said, well, I haven't said that to you. I said, but if you're telling me it's ridiculous that we can't cure your cancer, I need you to tell me what it is that's that's making you so angry. And she said, it's bloody obvious. So I said, okay. One more tack, right? And then she said it. She said, I stink of piss. Exact words. Right? It's like, oh my God. That was not what I thought was going to come out at all. I had no idea where we were going. And I said to her, well, I said, I've never said to you there's nothing more I can do for you. And I said, right now, it's not me who's going to do it, but there's a clever guy downstairs who's, I won't name, he was a consultant radiologist, nice, very good guy. And I said, I'm going to take you down to him, and we're going to get nephrostomy tubes put in, and you're going to be dry, pretty dry. And that's what happened. And she went home 2 days later, and she came back in a month later, and she died. She had been to see her friends, her family. She'd had lunch out. She'd had dinner out. She'd had an amazing last 4 weeks of life, and then she passed. So by asking the vital questions, we got to the answer. And I'm going to give you one more example, which is also, I think, telling, which is I sat down with a woman who was very close to the end. That was clear. But she seemed to be super anxious and hanging on to something. And I said, look, if I could wave a magic wand for you, you know we can't cure you. We know we can't. All we can do is to make you comfortable, basically. But is there something we could do for you? And she looked at me and she said, there is. She said, I've got a loft full of papers at home that need to be burned. The family must never find them. And they're going to, because I can't get home to burn them. I said, well, that's again, I said, I personally can't help, but I think there's somebody who can. It was Sister Leonoy, who was in charge of the ward, and she got staff nurse and she got an ambulance and they took the patient home and the staff nurse went in the loft, got the papers and they burnt them and she came back to the hospital. She passed the following day, right? So it's ask the right question, you find the answer to what's our patient's deepest troubles. So to go on now to the tour, we are going to compare Western and Japanese healthcare systems. And I know I can see at least one person here who was in Nepal and Bhutan, and we had a very interesting time seeing the Nepalese, Bhutanese systems and comparisons that were utterly fascinating, and I'm sure it's going to be the same. We're going to meet with members of the Japan Society of Obs Gynae and the Japanese Gynae-Onc Society, and as I said earlier, Prof. Keiichi Fujiwara is president of the IGCS and has very graciously agreed to host us when we're there, and we're visiting the National Cancer Centre as well. So I'm now going to move on to the second part of this talk, and just so you all know, I'm not going to chant it on for too long. This is a kind of 40-minute talk, all right, in two parts. And the next part is about infertility and the story of Womb Transplant UK, which in the book comes under Never Give Up, because it's a 25-year story. You all know this, that 100 women trying for a baby, 6 months out, 50 are pregnant, 12 months out, 80, 20 left. A year after that, 10 of those people have fallen pregnant with no treatment. The remaining 10 almost all need help, and they may have, I've lost my little arrow. Tubal infertility, IVF became the absolute solution for that. Ovarian issues, male factor issues, again, IVF ICSI, and then absolute uterine factor infertility, no uterus. And that's the bit that we're going to concentrate on. So do I have any conflict of interest here? I'm the chairman of Womb Transplant UK, with a charity that's designed to pay for the first 10 deceased donor and 5 living donor transplants. We have an active deceased and living donor transplant program, and I'm a founding member of the International Society of Uterine Transplantation. What I'm about to do now is quite UK orientated. And it relates out, though, all over the world. There are 50,000 women in the UK estimated with absolute uterine factor infertility. We know there are 1 to 200 women go down the route of surrogacy. We know that there are 5,000 plus women with Mayer-Rokitansky-Hauser syndrome. And in addition to that, we've got hysterectomy related to hemorrhage, hysterectomy related to malignancies, cervix, uterus sarcoma, GTD, gestational trophoblastic disease, and endometrial cancer. We've got Asherman's, fibroids, adenomyosis, benign conditions, and we've got over 500 women who've approached us for a transplant. We're also, this is fascinating, we're inundated with people wanting to altruistically donate their uteruses, right? We've got hundreds of women queuing up, dare I say it, to give their uteruses to other women, which is an astonishing thing. Most of our cases are nothing to do with cancer, less than 10%, they're mostly Mayer-Rokitansky. So if you are a woman with absolute uterine factor infertility, what options have you got? Well, there's surrogacy. It's got its own issues. So if you're Orthodox Jewish, if you're Muslim, you can't do it. There are legal issues. So the surrogate is the legal mother of the baby until the baby's put up for adoption by the genetic parents, and that creates its anxieties. And it's country dependent. And it's also in the United States, it's dependent state by state. And there are emotional issues. And I say my experience, and I've managed quite a few women, a good few, who've gone down this route. And it's been a big issue for them is what the surrogate is eating and drinking during the pregnancy. The advantages, there's low physical risk, there's good outcomes. Adoption is a very obvious approach. And then as uterine transplantation, well, as to state the obvious, it's major surgery to implant the graft. You're on immunosuppressive therapy for probably up to 5 years. And there's further surgery to remove the graft. And of course, you're going to have a cesarean section or two. Advantage, you get to carry your own baby and there are no legal issues. And actually, for a lot of ethicists, it's probably more acceptable than surrogacy. So who's eligible to enter our program? Well, at the moment, they have to be NHS eligible patients. They have to have absolute uterine factor infertility. They have to have embryos created by IVF from their own eggs in cold storage, 5 minimum pre-implantation genetic tested. And those women need to be between 24 and 42 years of age, and there must be no intercurrent medical conditions. And if they've had cancer, they're 5 years in remission, and it depends on the cancer, and they mustn't have a high BMI. Now, I want to bring something to your attention just at this point, right? Which is no intercurrent medical conditions, age 22 to 24, no high BMI. These are, by definition, extremely fit, healthy women, right? There are no other people stepping forward for transplant who are fit and healthy. If you're having a heart transplant, lung transplant, liver transplant, kidney transplant, pancreas transplant, you are sick. And this has proved a real issue in our program because we're taking very healthy people and we're making them not very healthy quite rapidly by what we're doing to them. And this is quite an important factor, which I know Isabel in her talk expands on in much more detail and in a better way than I can, because she's the one who's maybe more experiencing it from her side than we are. So, ethics of uterine transplant, I like to keep it quite simple here. And I'm well aware that I've attended conferences that last for days on this subject, but there are 4 pillars of medical ethics. I like the Rand Gillen, primum non nocere, first do no harm. We don't qualify. This project, as with much of modern medicine, what we're all doing does not qualify on that one. Beneficence, to do good. Well, we're scoring well on that because we're about the begetting of children, which is essential to human flourishing. Autonomy, excuse me, is the respect, as you all know, for the sentient patient who understands the risks, benefits of the procedure offered and willingly accepts those and signs up to do it. And really importantly, we've got a lot of healthcare worker people within our folk coming to see us and getting listed, etc. Justice, a concept familiar to all of us. The studies we've been involved in are all IRAS ethics approved, animal studies are Home Office licensed, Royal Veterinary College ethics approved, and also the Politecnicat de Valencia University approved. So human uterine transplant, the first case was Saudi Arabia, 2000, a 46-year-old with hysterectomy BSO for benign disease was the donor. Recipient was a 26-year-old, and it all failed at 99 days. Now, I know I can't see Giuseppe, but I can see Giuseppe on the screen there. Giuseppe Del Priore and I worked on this for many, many years and collaborated greatly on all this stuff. And at that point, here in the UK, we'd done a porcine series and we were down and out in 2000. I saw Nadi Hakim, Prof of transplant surgeon. He said use large vessel patch technique. And that's what we did, and Giuseppe did. Giuseppe did stuff in a primate model. We did stuff in a rabbit model and then a sheep model. And that has proved to be the technique that moved forward. And then we come to the second case, Turkey, 2011. And it's interesting because this was OSCAN. Now, Giuseppe and I, at that time, I remember us both saying to each other, we could stand up, and we've been in the arena of this research since 97. So what was that, 14 years? And between it, we could actually give away our entire intellectual property within the space of an hour. And any competent transplant surgeon could probably get on and do it. Well, that's kind of what happened. OSCAN, there was a collaboration with Mats Brandstrom. We'll come on to Mats in a minute. And the donor was a non-living donor. The recipient was a 21-year-old who was born without a uterus. 18 months later, post-transplant, endometrium prepared. Then they got into all manner of difficulties. And this uterus actually was morphologically not normal. But on a happy note, that woman has gone on to have a baby. Then comes the enormous success. And there is nothing but admiration for the bravery, dare I say it, of the woman who took part and the team that did this. Third to the 11th case, Sweden. Donors were all living. The recipients were related, non-related Mayer-Rokitansky-Hauser patients. And November 2014, the first baby was published in The Lancet, delivered by emergency cesarean section at 32 weeks. I want to tell you something, right? The day that came out, I had gone to Bristol to speak to the Southwest Obs Gynae consultants about uterine transplant. And I had been talking about uterine transplant since 1997. And at no meeting did I ever stand up and not get abused by somebody in the audience till this particular day. And I phoned Sasso, who was my fellow at the time, and said, "You're not going to believe this. They were behind our project. They really were behind our project." And an hour later, our PR guy phoned and said, "You need to know they've done it. The Swedes have got a baby and it's coming out tomorrow morning." And that's it. The project was over the line. 10 transplants were planned to be done by the Swedes. They did 9. There were 2 emergency hysterectomies. They had 7 further babies. So those women who retained their uterus is 100% fertility rate, right? Now, this is astonishing. I mean, I was an SHO in Glasgow when IVF started. In fact, I was at the delivery as an SHO of Scotland's first IVF baby, Bobby Lowe. Bobby set up Scotland's service. The first year, £250,000 worth of drugs shot into the women of Glasgow, and 1 baby came out, right? That was the experience across the country. This, for a very first series, unbelievable, right? So where have we got to now? Well, there's over 100 being performed worldwide, 80 published, mostly living donor, 3rd deceased. 1 case, which was post-cervix cancer, there's now 40 live births minimum. None of the babies have got any congenital malformations or anything like that. And the majority of births so far in living donors, been 5 deceased donors from the Cleveland series, big series, well performed. We were originally never going to do living donor because of the retrieval times of 10 to 13 hours. But the Dallas group with Lisa Johannesson and Juliano Testa, who are big collaborators and friends of ours, their new technique, which ironically emulated the technique which Giuseppe, who's here, and I and Laszlo Unger developed for trachelectomy, dropped the retrieval time down to 78 hours. And that's proved to be our kind of experience as well. So the patient pathway, I'm not really going to go into this evening, right? But basically, patients are referred to Charing Cross. They're assessed medically, psychologically with us, then in Oxford, and then they can get listed, and they're going to be on immunosuppressive therapy from transplant to hysterectomy. They're being observed for 6 to 12 months before an embryo transfer, then cesarean, then you're allowed 1 more baby, and then you get a completion hysterectomy. So the original Swedish technique, which we utilize for deceased donor, is retrieval of the internal iliac artery vein, uterine arteriovenous plexus. Uterus, we don't want to implant the tubes at the moment, although we may move to that soon. That's under discussion. And of course, we take a vaginal cuff. So there's your graft there. When it's implanted, Isabel Quiroga does the really tricky bit, which is hooking up these vessels onto the external internal iliac veins. And the uterus is stitched in at the vagina, round ligaments and peritoneum. So just to give you a kind of backstory here, I'm just looking at the time. We're okay for time, aren't we? It's a bit of a crazy situation, which is I've got a watch in front of me, which I know is quite an expensive watch. It doesn't always tell the correct time. I just want to make sure it's not running slow. Okay, so it's not. We're doing okay. So this is a 25-year story, right? And we're not going to dwell too much on it, but the animal work was all done at the Royal Veterinary College. And we did porcine small vessel transplant, total failure. Then we had success, porcine rabbit, and we did this human stuff, which I talked about. And That led us on to the rabbit transplants. We got the third pregnancy in the world in rabbit transplants, sheep auto transplants. And Giuseppe was collaborator in all of this. Then we had this Swedish success, and then I was mired in a whole load of quite difficult politics, to be honest. And Stephen Kennedy and Professor Peter Friend in Oxford said, why don't you bring the project to Oxford? And we went to Oxford. We were also in Valencia with Professor Jimenez doing endometrial transplants and protein-rich plasma. And then uterine transplant, Isabel Quiroga, Ben Jones, Salia Valley, and we've collaborated with everybody that's come our way. Molly Stevens, Professor Dame Molly Stevens now, FRS, youngest woman ever in history to be FRS, Professor of Tissue Engineering, collaborator. Maxine Chan was in her department, Jane Blaisby, Surgical Communication, Bristol, Steve Wilkinson, Law, and Natasha Hammond-Brown in Cardiff, Law. We've collaborated with all of them. So what happened with us? We took a long time to get there. 2015, we got ethics. And that's when Ben and Isabel were active in this program. They've been part of this for a decade. We then had to convince the Specialist Nurses Organ Donation, ITU consultants, British Transplant Society, FRCOG, Human Tissue Authority, NHSBT, NHS England, and RINTAG, National Advisory Group for Transplantation. And by 2019, everybody had said yes, but we still weren't going. And I was at the National Masterclass, which Isabel Quiroga runs as, on faculty in the bar at the end of the evening, actually, or end of the day, sorry, with Prof. Ploig, Rutger Ploig from Oxford. And he said, this is crazy. You guys have been made to jump through more hoops than any other group in British history. So he was on RINTAG and Senior Management Committee. And the next thing we had sign off. 2020, we went live, January, February, 6 call outs, none suitable, and then COVID arrived. And ironically, the practice patient, as we'd seen it, it was a woman with a large gestational trophoblastic cervical tumour, was the first patient in Hammersmith Hospital to have COVID-19. She was on my operating table and she took our entire team out. I'm fortunate, as are two of the young nurses and a young doctor, we recovered fully. Two people, one still on renal dialysis and the others had to retire from wrecked lungs. This was a car crash. It took us 2.5 years to get back on the horse. What kept us going is actually seeing these potential patients. So ours is a big collaboration. Isabel and Andrea in Oxford, IVF at Lister, Womb Transplant UK charity. Excuse me, you guys all know you want to do research, you write a grant application. I tell you, if you write a grant application trying to transplant uteruses, everybody just laughs at you. So we set up a charity. We were fortunate to meet the Baroness Cox, a very influential political figure, and very, very helpful, essential to the success that we've had. We're very grateful. These days, we've got two philanthropists, Nick Mon and Nadine Caneva, who've basically paid for 5 transplants, actually. Public relations, we've been protected by Neil Huband, and publishing-wise is John Harrison, Laurent Chaminade, and Richard Sharkin, who are all involved with the publication of this book and also the story of Womb Transplant UK, which will be coming out, hopefully, about the time we do our tour. So, surgical skill mix is fascinating. I'm a cancer surgeon, and I'm used to Halstedian principle of removing an organ with a 1 centimetre margin of tissue around it, good old Halstedian principle, and sealing vessels and hopefully causing minimal blood loss. That's absolutely not what transplant surgeons want. They want normal organs with nice vessels hanging off, and they do not like our devices that we use to seal vessels. So there's a lot of backwards and forwards in the theatre. I lead the retrievals, Isabel leads the implants. February 23, we had 2 sisters, came with their husbands and their parents, and a long, long day in theatre. That was the huddle, 30 people there. I want to just point out to you that guy there, right? Antonio, he was the cell saver man. He put his device on. It was a Sunday morning, so nothing interfered with NHS lists. He put his device on at 9:30 Sunday morning. He switched it off at 5:30 a.m. on Monday morning, right? He was there for both the retrieval and the implantation. This was quite some day, I'll tell you. That's the surgical team there. Living donor transplant, week 1, seriously stressful, right? We don't like return to theatre. If you do a transplant of a uterus, The world data is there's a 20% chance you are going back to theatre to take that uterus out. And as gynae cancer surgeons, we hate hemorrhage. Transplant surgeons don't care about hemorrhage. They care about thrombosis. So there's a huge amount of backwards and forwards. We had a big bleed. Night 2, I phoned Isabel. She said, no, that's cool. We just need to drop the heparin down. Night 4, Isabel phoned me to say the patient's pouring lymphatic fluid from her vagina. We went, no, we don't care about that, right? So this is a really serious collaboration. End of week 2, patient had a period and she had 2 normal cervical biopsies with no rejection. The world data is the vast majority of women who have a period will go on to have a baby, and we could relax a bit. So it's a long story. 25 years for me, 10 years for Isabel Ben. A lot of media issues. All of these groups, NHSBT, Imperial College, University of Oxford, Human Tissue Authority, NHS England, Womb Transplant, the patrons. Everybody's got their own public relations people, right? Nightmare. Anyway, it went out, BBC, Press Association, Daily Mail, a lot of publicity. So our little motto, I suppose, comes from Winston Churchill: success is not final, failure is not fatal. It's the courage to continue that counts, which I think is a great quote. I've put a second quote below because, of course, we're all off to Japan, hopefully, and only staying active will make you want to live 100 years. The tour that's proposed is fantastic. There's a lot of activity. It does require an element of physical fitness, I think, to do some of the things we're going to do. I think there's a gradation, so people know about that. So it should be medically instructive. It also should be good fun, I hope, on many, many levels. That is the website, and that takes me to just a little bit more about the tour. We are going to visit 2 of Japan's 3 great gardens. And of course, this is autumn, isn't it? It's going to be amazing. The 2 times to be in Japan, as I understand it, are spring and autumn. We're seeing the imposing Himeji Castle, and we're going to see some lesser known Japan, as it says there. There's a cruise across the inland sea. And for those that are up for it, there'll be a pre-tour to Mount Fuji and Lake Ashi, which I might be on myself, actually. That's certainly on my agenda. So I got one little final picture to tickle your fancy, I hope, which is rather atmospheric. And that's I think I've said quite enough. I'm on my 35 minutes out. That's good. And I'm happy to take any questions from anybody.